Hello, everyone. As you get signed in, you should see a poll pop up. If you can fill this out, that'd be great. If you want to, now would also be a good time to drop in to let everybody know where you're calling in from. People are from all over. Welcome, everybody. I am going to end the poll here in just a few seconds. It's not anything that you'll need for any of your continuing education units, just something for us to get to know who all is attending our webinar. Alrighty. All right, so let's just go ahead and get started. Welcome everybody to our MPG webinar series. Thanks for filling out the survey if you did. Again, it's not anything that's required. We have about 50%, half and half that are new. So welcome everybody that's new, and everybody that has previously attended, welcome. Okay. Francine, if you want to go to the next slide. Before we begin the webinar, I'd like to tell you guys a little bit about Manhattan Psychology Group. We were established in 2011 by Dr. Joshua Rosenthal and have continued to grow into a team of over 300 dedicated professionals. Our team includes skilled adult and child psychologists, neuropsychologists, behavior analysts, special educators, and ABA therapists. As a team, we are committed to wraparound care, which includes our wide range of services from mental health and testing to ABA and educational services. This holistic approach allows us to address various needs and challenges with compassion and care. We provide services to our clients out of the Upper West Side and Long Island City offices, in-home, school, and clinic-based settings, as well as through telehealth. Our team is committed to serving individuals, couples, and families of all ages in diverse settings. We're also pleased to offer these free monthly webinars for parents and professionals, where we'll continue to learn and foster meaningful connections. Our vision at MPG is to create a future where individuals and their families feel supported, connected, and empowered. Our mission is to provide a multidisciplinary, integrated support for individuals and their families who experience mental health, behavioral, and educational challenges. All right. Now for some housekeeping information. This webinar is eligible for continuing education through the BACB and for New York State licensed psychologists and licensed social workers. A link for the quiz regarding the content of this presentation will be posted in the chat and on the calendars within the last 5 to 10 minutes of the presentation. There will be no code words. The quiz will be multiple choice and it will pull from the content of tonight's presentation. The shared slides will be posted on the webinar calendar as well. We'll be closing the chat during the content of today's presentation, so any questions that you have, please post in the Q&A so we can make sure that they're seen. Any questions that have been unanswered during the end portion of the webinar will be sent to Dory and Francine for them to answer some of these questions. Okay. And now to introduce our presenters. Today we have Dr. Francine Zeltzer and Dory Barbanel. Dory is a licensed master social worker in New York and New Jersey, as well as a board-certified behavior analyst. Dory's passion is working with special needs children and their families. Serving families of over 15 years, she believes in using evidence-based practice to improve learning, build skills, and help children achieve their maximum potential. Dory has years of experience designing and implementing home and school-based ABA programs tailored to the individual needs of each child. A point of emphasis for Dory is teaching and supporting families to carry strategies and across settings and caregivers. Dory draws on her background in social work and child development. She specializes in working with children and their families and is internationally certified in parent-child interaction therapy. Her practice integrates a social work approach by meeting children where they are and then guiding them to excel through the use of behavioral principles, playfulness, and genuine appreciation of the uniqueness of each child. Dr. Francine Zeltzer is a New York State licensed psychologist. She's the director of mental health and testing at MPG, who oversees a team of licensed psychologists, neuropsychologists, and psychotherapists who provide counseling and assessment services to children, adolescents, and adults. Additionally, she coordinates the psychology internship and postdoctoral fellowship program. Dr. Zeltzer specializes in a wide range of services from child and adolescent development to psychological and educational assessments. Her integrative approach enables her to provide high-quality, evidence-based treatment to address the diverse and unique needs of her patients. And now, without further ado, I'll hand it over to Dory and Francine for tonight's webinar on toileting.
Thank you. Hey guys, I'm Dory. Thanks for joining our webinar tonight. So we have 4 main objectives for our webinar tonight. I'm sure everybody is familiar with potty training generally. There's a lot of different approaches. So what we're really focusing on tonight is, first of all, understanding how to identify if your child is ready for toilet training. We're going to learn options for bowel movement training if children are only voiding urine in the toilet. We're going to be learning the intensive toilet training procedure outlined by Frank Cicero. He also has a non-intensive procedure, but we're going to be focusing on the intensive one tonight. And we're going to be identifying strategies if your child is afraid to sit on the toilet.
Great. Good evening, everyone, and welcome. We're going to start this evening by talking about readiness, because the first question we're often asked is, how do I know, is my child or the child that I'm working with ready to be toilet trained? So readiness can be defined by any of these different variables, and it could be one for one child, it could be most of these for other children. So the first thing is, can your child sit on a toilet for at least a few minutes, or at least sit for a few minutes, even if not on the toilet? Is the child able to hold their urine for 60 to 90 minutes without dripping or leaking? Is the child able to understand consequences and rewards? So the concept of cause and effect. Do they show awareness about voiding, and do they recognize the sensation of having a full bladder? Is the child able to comply with minimal tantrums or compliance difficulties? Are self-stimulatory behaviors managed or minimal? Are they able to locate the bathroom independently? Are they able to communicate either verbally or non-verbally their need to go to the bathroom? Are they able to take off their clothes, wipe, flush, redress, and wash hands with minimal assistance? And most importantly, is the caregiver or the provider ready to implement the training procedure with consistency? So often the child might be ready and the parent might not be ready, or the caregiver is ready, but the child might not be. So it's really about finding that balance between both the child and the caregiver or provider to ensure that that training will be successful.
Okay. So we're going to go into Cicero's procedure now. And our first step here is to assess what kind of potty training are we looking at? Are you looking for overnight training? Is your child able to use the bathroom consistently and independently throughout the day, but consistently having accidents at night? In that case, we're looking at overnight training. Maybe your child was once toilet trained, but they have stopped voiding in the toilet, or they've had a recent notable increase in accidents. Then we're treating regression. We might be working on requesting. So a lot of kids will be on a schedule of when they use the potty, and then parents or teachers will be confused when they're having accidents because they might get off that schedule. And it's important that kids can identify that they need the bathroom and request for it so that they're able to get what they need when they need it. Is your child great with urinating in the toilet, but having frequent bowel movement accidents? Then we're looking at bowel training. Or maybe your kid's never been potty trained, they have accidents during the day, they're still in diapers, they're requesting to, or they haven't started requesting to use the toilet. Then we're talking full toilet training. And this assessment step is important because what we're going to do for these 5 things might not look the same. So first we have to identify what we need so that we know what to do. Okay. So there's 2 different ways we could look at this from Cicero's perspective. The intensive one is faster, which a lot of people appreciate. But it does result in significant short-term changes to a child's environment and routine. All the training takes place in or very close to the bathroom. The child doesn't have access to their whole house or to their whole classroom. Their typical activities are put on hold while potty training is being implemented. And this can be really tricky, especially for parents who have children with special needs. You might be hesitant to pause learning in areas where they really need to be making progress in order to potty train. So that's something that every family has to think about. It requires more training and time for the adults implementing. And children will learn to initiate independently and spontaneously, which is something that makes this procedure a little different from a lot of other procedures, is that there's no schedule. Kids identify they need the bathroom and they tell you, or they go themselves. The non-intensive procedure can be helpful because if you don't want it to take over your whole life for a weekend or a week or however long the procedure takes, the non-intensive might be a better option. The child's going to be brought to the bathroom every 30 minutes to try and avoid in the toilet. They can be schedule trained instead of self-initiating. It does take longer. So kind of the cons of this are your child's not self-initiating. It takes longer for them to learn, but it's a lot less demanding on the adults.
So tonight we're going to focus more on the intensive procedure. And then there are certain steps in order to have success with the intensive procedure. The first is to make sure you, as the adult who is doing the potty training, is prepared. The first thing you need to understand is how much time you need in order to effectively implement this procedure, because the child needs to be supervised one-on-one. They have to be constantly watched from a person who's trained in this procedure for multiple hours every day for days in a row. And you want to ask yourself, can I support my child, or can my other child's caregivers, whether it be their teachers, their babysitters, whoever they're with throughout the day, can they support my child and support me in maintaining the integrity of this training program? And if the answer is no, that's okay. Then the intensive procedure is not for you, and you want to use a less intensive approach. And then you want to prepare your home environment, or the environment in which training will be occurring. So once you say, yes, this procedure can work, I do have the resources, how do we set up for it? So the first thing is to set up for training to take place in or next to the bathroom. So if you have a very large bathroom, you can actually set up within the bathroom. If you don't, that's okay. We could set up right outside the bathroom, but we want to bring the child to the bathroom instead of bringing the bathroom to the child. So we want to do this in an actual bathroom. And we do this by setting up a small table and 2 chairs and a bunch of activities that the child finds reinforcing and enjoyable in or outside the bathroom, so that it's a stimulating space that the child wants to be in. And then they are able to continue to do the activities that they would typically do during the day in the bathroom or in this space. So if every day at 11 a.m. you do story time, you could do story time in the bathroom or right outside the bathroom. So you're maintaining your normal routine, but you're just changing the environment and location. And the third part, which is preparing the child. So we want to make sure that we have medical clearance, that the pediatrician is giving you the thumbs up. Yes, it's okay to start toilet training. We want to make sure that the child is not in diapers or pull-ups while we are implementing training. And we want to limit clothing in order to quickly detect any kind of urination underwear. So this will vary from one child to the next, because we want the child to still feel comfortable during the procedure. Some children will feel comfortable if they are wearing nothing but a t-shirt, then that's fine. For the most part, that's unusual for a child, and some children feel very uncomfortable. So we would just put them in a pair of shorts or a pair of gray underwear, something that's easy to detect whether or not it becomes wet. So gray is definitely a preferred color. We also want to make drinking a desirable thing. So we want to have a number of liquids available for the child. Liquids could be in a variety of actual drinks or foods that are high in liquids. So like fruit is a great example, ice pops, and any kind of drink, even if you're not a juice drinker for toilet training procedure purposes, you can introduce other liquids because the more they drink, the more opportunities to practice that the child has. And then you want to isolate or identify a highly preferred reward that can be given upon successful voiding.
Okay, so there's 3 components to this training. The first is a prompted toileting schedule. The second is teaching of the request. And the third is accident correction. And we're going to go over what all of these things mean. So the prompted toileting schedule means that every 30 minutes, if your child hasn't requested, you're going to prompt them to use the toilet. So we're avoiding verbal prompts because these can be really difficult to fade, and that discourages independence. And our big point of emphasis here is that your child will independently be potty trained. So we'll use the least intrusive gestures and physical prompts possible. And what that means is we're not going to be picking up our child and plopping him or her on the toilet. We might be pointing to the toilet. We might even just show a picture and point. We're going to make it as subtle as possible. Once the child is seated on the toilet, we want them to sit there for 3 minutes or until they've voided something. So while you're waiting for those 3 minutes, they can feel interminable. You can say something like, okay, go pee on the potty, but you don't want to overdo that prompting because you don't want your child to only void when you're telling them to. You want them to be able to do it independently. Once they begin to void, there's a big temptation to start throwing a party and getting really excited or screaming or cheering, but you actually want to stay really quiet until they've finished, because when you interrupt the stream, it can be difficult for them to finish or they can miss. And we also don't want kids to void incompletely and reinforce that. What can happen is children will pee halfway and you'll start cheering and then they'll stop because they're getting that reward from you, and then they'll get up and have an accident. So we really want to make sure that we hold our applause until they're done. You can smile and be excited, but you don't want to throw your party until you're sure they're done. Once they've finished, you're going to, again, gesturally prompt them to stand up and pull up their pants. It's okay if they need a little help with this, but we're not using verbal prompts. As this is happening, you're providing behavior-specific praise as well as your isolated, targeted reward. So what is behavior-specific praise? You're really describing what they did that you liked. I love how you sat still and you peed until you were all done and you got all your pee in the potty. I'm so proud of you. I love how you sat, even though you looked uncomfortable, until you were done with that BM. Whatever they did that you're proud of, you're going to describe it really clearly. And then, we're going to have our special reward. So this really varies widely from child to child. I know a lot of parents have mixed feelings about food. It can feel gross to give food as a reward in the bathroom, but at the same time, it's consumable, and so you don't have to take it away later. So some parents will start with something like mini M&Ms. It's not likely to be dirty. Other parents might use stickers, bubbles, whatever's going to actually be a powerful reward for your child. It can be really tempting to give them a raisin, but if your kid doesn't like raisins, they're not going to be reinforced for using the bathroom. So you want to choose something that they're going to be really excited to get, that they only get for using the toilet. So our routines like hand washing, we want that to happen after the praise or reward. And I know that can also sound a little gross, but this is something that we can fade later. What we really need to do is make sure they associate voiding in the toilet with their reward. And once they've made that connection, you can wait till they've washed their hands and everything to give the reward. And then once they are done washing their hands, we're going to reset our timer for another 30 minutes.
So I just want to talk about the schedule a little bit. So we talk about 3 minutes having the child sit, and as Dory said earlier, sometimes that 3 minutes could feel like a lifetime, and children become very restless and difficult to sit for 3 minutes. So something that I have found to be very effective is putting on a song or having the child sing a song, which often is 2 or 3 minutes, or any kind of a rote counting procedure tends to work also, because it has a clear beginning and an end. So if the learner is frozen obsessed, they want to listen to a whole Frozen song, that same Frozen song could be played for the full 2.5, 3 minutes that they're sitting. And that way they know at the end of the song, you're able to get off, and it allows them to kind of feel comforted in that there will be a beginning and an end to the trial, because if a child is sitting and they are tense or stressed, they're less likely to void. So a child will sit now for the full 3 minutes. And if after the 3-minute interval is over, if they haven't gone to the bathroom, you would prompt them to stand and dress. You could say something like, okay, I guess you don't need to pee now. And you want to make sure that that statement is very neutral. You want to keep a neutral tone. You don't want to have too much of an affect. You don't want to suggest that you're disappointed or that you're happy. You just want to give the very generic prompt. You didn't pee, it's time to come off. The learner does not receive a reward or any kind of verbal praise. We're just giving them the prompt. You sat, you didn't pee, come on off. And then we're setting the timer for 30 more minutes. It's really important using this method, even if you suspect that the child does need to use the bathroom, that you do not extend their sitting time or add another trip to use the toilet between the 30-minute intervals. In this particular procedure, the accidents are a really important part of the training. So we are not using an errorless learning procedure. We are not trying to avoid accidents. We want to make sure that the child or the learner is brought to the toilet every 30 minutes. And outside of that the 3-minute sit, then they go back and we wait for another 30 minutes. However, if the learner does request either verbally, gesturally, they go towards the bathroom, they are able to access the bathroom. So we allow them to access the bathroom. We don't block it, but we also don't prompt them outside of the 30-minute interval. So overall, with the schedule is 30 minutes off, 3 minutes on. We want to prompt the child to use the toilet using only gestural and physical prompts. We do not want to give any verbal prompts to use the bathroom. We want to have the learner sit on the toilet for up to 3 minutes. If they do void, if they have a bowel movement, we want to reward them with verbal praise at the completion of that activity. So we want to make sure that we're not interrupting that activity. We want to wait till it's completed, and then we want to deliver the verbal praise. If they do not void, we want to use that same nonverbal prompt to guide them off the toilet, or a very neutral verbal prompt. And then we want to reset the timer for 30 minutes.
Okay, so in terms of training requests, fostering independence is really what I like about this program, and I think sets it apart from other programs. So you really want to decide the most functional, easy mode of communication for your child. So for some children, that might be verbal. It could be gesturals, it could be sign language, it could be PECs. However your child most comfortably communicates is fine. Prior to each trip to the toilet, you're going to prompt your child to use their request. And again, we're avoiding verbal requests. So however you can prompt them, if your child's a reader, you could hold up an index card that has what it says. It could be a picture. However your child communicates, you're going to, as non-intrusively as possible, prompt them to request. Once the request has been made, you're going to have a natural response like, okay, you want to use the potty, let's go. Just really natural. You don't want it to become a rote scripted experience. We're going to just say, okay, let's go to the potty. You asked really well. And then we're going to go to the toileting schedule that we outlined previously.
Great. And I saw a question in the Q&A about why we're avoiding the verbal prompts. And that's really because we're working towards fostering independence, and the verbal prompts would be less helpful in terms of fostering that independence. The nonverbal prompts are better for that. So we're going to talk a little bit about accident correction, because as we mentioned earlier, we are expecting accidents to occur during this method. It's part of the training procedure. So we want to watch the individual very closely. I always say to watch them like a hawk. And you're looking at any kind of behaviors that might be a precursor. And we're also looking for any form of an accident or any form of wetting. So we want to watch their underwear, or if they're not wearing underwear, if they're naked from the waist down, we want to look at the chair that they're sitting on and see, does it look wet at all? At the start of the accident, here's where we want to startle the child using that loud verbal statement and physical prompt to get them to the toilet. So remember how Doria and I said earlier that we don't want to have that celebration party midstream while they're voiding because it might actually stop the stream. Now, because they're in an accident, we actually do want to make that loud verbal statement that might startle them, but it will likely stop the stream and give us that time to prompt them to go to the toilet. We want to encourage them to urinate on the toilet. And then if they do, even if the urination starts elsewhere as an accident, if they are able to urinate on the toilet and finish on the toilet, we want to give them that verbal praise and reward as if they completed the trial successfully. If they go onto the toilet, but then after that 3 minutes, they were not able to void on the toilet, we want to respond as if this was a non-success or no void. And then we want to prompt them off the toilet and provide as little attention as possible so they're not getting that reward. And again, we want to continue to monitor underwear for signs of another accident. So this is the procedure that is likely to occur between those trials. So remember, we have a 3-minute trial every 30 minutes. The only two exceptions within that 30-minute window is if a child or a learner self-initiates going to the toilet, then they go to the toilet. Or if they're having an accident, then they go to the toilet. So if we suspect that their urgency is increasing, that they haven't gone for a while, we would expect to see signs of an accident or an accident occurring. So we might actually end up going back to the bathroom multiple times within that 30-minute window. If we see that they start having an accident, they get onto the toilet for the 3 minutes, they don't void, and then they go off, and then they go back on if they start having that accident again.
Okay, so that's really the bare bones of the intensive procedure. And now we're going to discuss fear of using the toilet. So this can be a little tricky, especially with our early learners to identify. First, you want to make sure that this is a sincere fear and it's not ritualistic. Kids can get into patterns, both neurotypical and neurodiverse children can get hooked on patterns that can look like fear, but really be rituals. And if it is ritualistic, we'll treat it differently than if it's sincerely fear-based. So first, you're really going to want to, your child best, and you're going to want to assess really carefully to make sure this is fear-based. We're not using any punishment procedures for children who are afraid of the toilet. That's just going to increase their fear and avoidance. It's going to make it worse. Nobody wants that. And again, we're going to isolate a reward that's highly preferred for children to earn for success. So the procedure that we use here for fear-based challenges is called graduated exposure. It's going to be a really slow introduction. So first, you might allow your child to be in their pull-up or their underwear or even fully dressed, sitting on the toilet. If they're really terrified, maybe they stand next to the toilet. Maybe then they put their hand on the toilet. Maybe then they sit on the toilet. But you're going to gradually reduce the barriers after a few days of success. So if you have 2 days where your child is sitting fully dressed on the toilet, then you might leave the diaper or the underwear and just take off the pants. And then you'll have 2 or 3 days of success with that. And then you might remove the next barrier, whether that's a pull-up, whatever it is. Any success that they have in this process, we're going to reward. So if, okay, yesterday you were scared to be in the bathroom and today you stood in the bathroom, here's your mini M&M. I'm so proud of you. That was really brave, right? And we're going to be rewarding all of these little baby steps that lead to eventually sitting on the toilet. If your child has receptive language skills, it can be really great to read stories about going to the bathroom on the toilet. So this can reduce anxiety for a lot of children because it makes the experience predictable. For some kids, a toilet can be really mysterious. It's just this giant hole. Like, why am I sitting on it? Is something supposed to come out of it? I'm not comfortable. When you read these stories, kids understand what happens when we sit on the toilet, why we sit on the toilet. If your child likes cartoons, just about every cartoon show has a potty training book, or you can make your own really easily. You can take pictures of your bathroom and your child, and you can make your own social story so they know what to expect when they sit on the toilet. And maybe you can show a picture of them receiving the reward. That can be really motivating for some children. If you're using a story, you don't want to start with a story in the bathroom, which is already a scary place. You want to take the story when they're calm and in a good mood, and you want to read it then. And once they're comfortable and used to the story, then you can start reading it before each trip to the toilet. So they've already had this positive association with the story. The story's not scary, and they'll get that information right before engaging in what had been or could be a pretty scary situation. Ideally, it would be great to read that story before you get in the bathroom. But again, we're not going to start there. We're going to start with reading the story when your child's already comfortable and not near the bathroom.
Great. And I see a lot of questions are coming through the Q&A. We're doing our best to answer the questions as they come in, but we will be addressing a lot of these topics through the second half of the presentation. So please bear with us and we will get to your questions. So now we're going to pivot to talking about bowel movements. So when it comes to bowel movement training, data is our best friend, and bowel movement training is very different than urination training because bowel movements often occur at a much less frequent event than urination. You might have 5 or 6 opportunities with urination in a training interval or a training day, whereas you might not even have a bowel movement training opportunity within a training day. So before we start an intervention, we want to collect what we call baseline data, which is the pre-intervention data that we are collecting on the learner's bowel movements. This information helps us understand which strategy or procedure would be best to use to help train the bowel movements and when the bowel movement training should occur, because there tends to be patterns of bowel movements in individuals. So this is a little bit different because we want to collect information on the actual day of the week, the time of the day, the location where the bowel movement occurred, the consistency and the size of the bowel movement, as well as any precursor behaviors or particular behaviors that occurred prior to or while the bowel movement was taking place. So this might be something like your child hiding when they know they have a bowel movement, or a child having a certain stance prior to or during the bowel movement, or a silly behavior acting in a ritualistic way prior to having a bowel movement. So when it comes to collecting data, we want to always look at the frequency, the duration, and the intensity of not only the bowel movement itself, but all of those behaviors that come prior to or along with the bowel movement. And this really helps us predict when a bowel movement is most likely to occur so that we could target that window for our training. So what exactly are we looking for before we start our bowel movement training? So the first thing, similar to urination, but particularly important with bowel movements, is for pediatrician approval to make sure that you have medical clearance to go ahead and start a plan, especially if the child has a history of constipation or impacted stool that needs to be addressed or hasn't been addressed. Because when it comes to bowel movement training, if you want to set yourself up for success. And if the learner is going through a cycle of constipation, it is going to be really difficult for them to have success. And it could be very, very uncomfortable, very painful, and very stressful. So we want to address any medical barriers that might interfere with the training prior to starting a training protocol. And that's why with bowel movements, it's really helpful to have the learner in a state of regularity before we start any type of training protocol. We also want to look at the different patterns. Time of the day, is the learner going to the bathroom within 30 minutes of a meal? Do they tend to go more often in the morning or more often in the evening? What is the consistency of the stool? Are there any patterns of withholding? Is the stool hard or difficult? Is the child straining? And then, of course, if there are any issues related to constipation or withholding, we want to address that before implementing a training protocol. Because if the child isn't ready to be trained, which means they're in the middle of a constipation cycle or they're impacted, it would make it much more difficult to successfully train them. We also want to look at these related behaviors. Does the child have a certain facial grimace or a pattern of behaviors? There's a lot of kids who get clingy or want to be picked up prior to having a bowel movement. Other children might not want to be on their feet because it puts pressure on their bowels. We discussed before the hiding behavior, or just different actions or movements that the individual might engage in prior to having a bowel movement that are a signal for that person and any caregiver that a bowel movement is coming. And then you want to take data until you notice a consistent pattern. So I always say a minimum of 3 to 5 days of baseline data is really helpful. You also want to have baseline data across different settings. So you want to have 2 or 3 days of baseline data on, let's say, the child's in daycare or school, a school day, or a weekend or a holiday, so that you are able to see, are there consistent patterns for different settings or different patterns for different settings. And we want to be a bowel movement detective. So it's different than urination because when a child or a learner struggles with urination elimination, there's usually a skill deficit. When it comes to bowel movement challenges, there can be a skill deficit, but there often are behavioral issues that are barriers for bowel movements. So we need to make a plan that's based on the why. Why is this learner struggling with bowel movements? Is it a skill issue? Is it a will issue, a behavioral or a motivation issue? Or is something else going on here, like a medical issue that might be a hindrance for that particular learner? And like I mentioned before, we are always looking for those precursors or those cues that signal to the caregiver or the provider that a bowel movement may be coming. That might look like passing gas, standing in a certain postured position, a clinging behavior, signaling to be picked up, the weight shifting while standing, often known as the PP dance, or laying down to take pressure off of bowels. So all of these cues or behaviors indicate that there is an imminent bowel movement.
Okay. So sometimes you have a learner who isn't having bowel movements because of a skill deficit. So a skill deficit just means that this child hasn't learned or figured out how to have bowel movements in the toilet. Maybe they can have urination in the toilet, but that skill doesn't necessarily generalize for all children. And it might just not have generalized from urination training. This happens really frequently with younger children or parents who are really excited about potty training who start when that child is just 2, or I've even seen 18 months. Sometimes those kids need a little help to generalize that across all the movements they can be having. So if this is the issue, if your child just has a skill deficit, we just need to design and implement a traditional bowel training intervention. So this just looks a lot like what we talked about before. We're going to use reinforcement, and we're going to fade the reinforcement as skills develop. That's a great way to elicit a new or challenging skill. Sometimes when bowel movements can just be trickier, you might want to double the reward. 1 mini M&M for pee, 2 for bowel movements. Sometimes that can just get kids over the hump, and then we fade that reinforcer as soon as we know that is a skill that's in their repertoire. But again, if it's a skill deficit, we never want to penalize or punish or make children feel uncomfortable if it's something that's not in their repertoire. If it's a skill deficit, they don't know how to do it, and it's our job as parents or teachers or therapists to teach them. Okay. So let's say that we do need to train for children who have a skill deficit for BMs. The first thing we're going to do is decide the best time of day to implement training based on that baseline data Francine was talking about that we've collected. And you want to try to begin 30 minutes before you anticipate the bowel movement is imminent. And that can seem like a long time. But it's important we start 30 minutes in advance because we don't want to miss it and because they can take a while. So once you've figured out your isolated reward that you're isolating for BMs, and that's again really important because if this was easy, your kid would be doing it. And what motivation does your child have if you're not rewarding them? Most children actually don't mind pooping in a diaper, especially when you change their diaper. That can be a special time. They're getting a lot of attention. They're being pampered. Even if kids are fighting when you're changing their diaper, they're still getting a lot of attention from you. And so a lot of parents will say like, oh, my kid hates getting their diaper changed, so I don't need a reward because the reward is no more diapers. Most kids aren't making that connection. And we were talking about ritualistic patterns earlier. Some children kind of get used to that routine of I fight during my diaper change, and it's familiar and it's comforting. And it sounds perverse, but some kids actually look forward to that. Even if it's not the nicest experience for you or for them, having something that they can anticipate, that they have control over, they know what to expect. A lot of children find that very powerfully motivating. So we need a reward that's going to compete with all the attention and all the familiarity of a diaper change. And so we will fade that reinforcer over time, but when something's really hard, the reinforcer is extra important. So step 3, we're going to be bringing the child to the bathroom every 10 minutes based on the timing provided by your data. So this is individualized to every child. You're going to use your baseline data, and you're going to be bringing your child to the bathroom every 10 minutes based on the timing, starting 30 minutes before you're anticipating that BM. So you'll prompt them to sit on the toilet, and you're going to instruct them in a neutral tone of voice to have a bowel movement. We want this to be really neutral. If we're only using our super happy voices, then kids can withhold unless they feel like you're going to be really playful. If you sound angry, it can make kids scared. We don't want this to be based on your tone of voice. We want this to be based on their bodies. So really neutral tone of voice. You're just going to say, okay, it's time to poop. You can use pictures if your child has limited language skills, if they're not going to understand what you're saying. It's gross, but you can use a picture. You're going to bring the reward or a picture of the reward into the bathroom, and you're going to remind them that having a BM on the toilet is how they earn that special reward. So for BMs, it's a little bit different than for urine. You're going to try and have them sit for approximately 10 minutes. BMs take longer. 10 minutes is a long time. But we need to make sure that they sit long enough to void. And if your child has a skill deficit, it's not unlikely that it might take them longer to do this. If a BM is observed, you're going to reward with behavior-specific praise, like we described earlier, and the isolated reinforcer. If they don't void after 10 minutes, you're going to give them a 10-minute break, and then you're going to try again. If an accident happens in those 10 minutes, you're going to have them help you clean it up and change their clothing while providing as little attention as possible. And you're going to stay really calm. This cleanup thing is not intended to be a punishment. It's just a natural consequence. When we have accidents, we need to get clean. This isn't you saying you have to clean this up, bad job. This is just, oh, If I do this off the toilet, I have cleaning to do. If I do it on the toilet, I get my favorite prize. We want to draw that distinction for them. And then after 10 minutes, you're going to pop them right back on. And we're going to continue this process either until they void in the toilet or until bedtime. And we're going to continue collecting data so we know if modifications need to be made. So you might notice, I took my baseline data 3 weeks ago, and now I'm taking data and I'm realizing his BMs are coming an hour later than they used to. So I'm going to move my 30-minute window from 1 o'clock to 1:30. And so I'm not going to waste time. And that's part of why this data stays really important. We also want to notice things like, oh, his poo is getting a lot harder. Like I might need to change his diet, or he didn't, during baseline data, I didn't notice this, but here I'm seeing like he looks like he's in pain. We might need to go to the pediatrician and talk about his diet or things that we need to change to make this more comfortable for him. So even though data can feel very clunky, it's important we keep taking it so we have a really good understanding of what's going on and we can make necessary modifications in real time.
Great. So the physiological issues that we started talking about before are often identified through the data collection. And this has a lot to do with hard or impacted stool that might signal constipation, loose stool that might signal a virus or other dietary issues, or, behavioral indicators like straining or pain when having a bowel movement might be suggestive of either an impacted stool or not having the necessary control over the muscles. So we want to make sure that we are partners with pediatricians and parents in terms of addressing these issues as they come up, because this often signals that there is an underlying problem. And if the pediatrician is not able to provide guidance to the parent, then it might be time to suggest that the parent bring the learner to a specialist, because we need to address those underlying issues prior to implementing a plan.
Okay, so sometimes your child's not voiding in the toilet because they are non-compliant. Parents, teachers, therapists, you probably know if this is what's going on. Kids may not eliminate on the toilet because they want to be in charge. They're not listening on purpose. In this case, an accident is not an accident. An accident is an intentional, purposeful behavior, and we need a behavior plan to address it. So kids who are not compliant around BM training, it's usually not just BM training. We usually notice that they are non-compliant in other areas as well. This is not your first rodeo. And so if you're a behavior analyst, you can whip up a behavior intervention plan. If you're not, if you're a parent or another provider, you can work with a behavior analyst to come up with a plan to address this non-compliance. But this isn't about training for the toilet. This is about reducing non-compliance and requires a different type of interaction from us.
Absolutely. And if there's no medical reason, this is often where we see some withholding behavior as a child's way of maintaining control. And that also is a form of non-compliance, which should also be addressed from a behavioral lens rather than a training or a medical lens. So it's just important to understand the learner's temperament and look at these patterns, not in isolation with toilet training, but as looking from the wider lens of how does this play into the person's temperament, personality, and general behavioral patterns, and what kind of supports might be needed outside of the traditional training protocol. And then we have those learners that are fearful of having a bowel movement. And this can often be tricky to assess because not all kids, even kids that are verbal, are able to explain why they are scared or able to identify that they are scared. For some children, the act of sitting on the toilet and releasing a part of their body, which feels more of a process than urination is just a scary experience. And then others have had painful bowel movements. And then there's a lot of fear of it hurting or it being difficult or it being uncomfortable. So when it comes to a fear, we also want to address this from a behavioral lens and better understand what might be motivating the fear and then putting an intervention in place so that we're able to address the anxiety or the fear prior to implementing the training protocol.
Okay, so another reason why we might have challenges with potty training can be ritualistic patterns. We see this more frequently with kids on the autism spectrum, but it happens in neurotypical children as well, or children with other diagnoses. So bowel movements outside of the toilet could be part of a child's ritual or routine. And if you have a child who is routine-based, you know that they can be very resistant to changes in rituals or routines, and children also often seek access to those rituals. So just like with noncompliance or fear of elimination, for kids who are attached to the routines, eliminating outside of the toilet is not an accident. It's a purposeful behavior that's maintaining a preferred routine that's been established and reinforced. So for children who have these ritualistic patterns of voiding outside of the toilet because it's part of a comforting, familiar routine, and it's something that they are used to, that they crave, we're going to need a behavior intervention plan for this type of child. So that's going to be different for every child. It could involve a lot of what we talked about, but have additional components. It's really going to have to be individualized. And so again, you're going to want to work with a psychologist or behavior analyst to individualize a behavior intervention plan for this type of behavior.
Great. So this is our last slide, and we might have enough time to take a few questions, but it's really important, whether you're a parent, a caregiver, a provider, a teacher, to know that there is no one size fits all approach to toilet training. Every child, every learner, every individual is different. So what's most important is that you're able to remain calm and neutral throughout the intervention, and that you're able to implement the intervention with consistency to determine whether or not it is effective. So we are always encouraging the collection of baseline data and intervention data throughout the trials to identify which training approach would be most appropriate. And then when you implement the approach, is the approach working? How do we know if it's working? I would say no less than 3 to 5 consecutive days of trying that approach before saying, this really isn't working. Let's try something different. Because often it could take a few consecutive days of exposure to the protocol before the child or the learner is able to demonstrate any kind of success. So if you're switching interventions too quickly, you're not giving the learner the opportunity to be successful. Training and any type of intervention can be really stressful, especially for parents and caregivers. So engage supporters. You don't have to do this alone. Seek out the support of trusted individuals who can support you in holding yourself and your child or the person that you're training accountable and help you in terms of implementing the plan. If you need a break and you're using an intensive intervention, can you tap out and somebody else taps in so that the intervention is able to be continued with fidelity without you finding yourself in a frustrated state or frustrating the individual who's being trained. And then remember to celebrate those small successes along the way. This is a process. You often will take a step back before you take 2 steps forward, and that's okay. It's all part of the process, but you really want to remain neutral during these setbacks. Know that they are expected, and make sure that you're giving yourself as the trainer and your child or individual you're working with the reinforcement for their success. All right. So we have about 5 minutes, so we probably could take a question or two. You'll see in the chat box, we put a link to these slides. We put the links to the quizzes if you're looking for CE credits as a BCBA, as a New York State psychologist, or as a New York State social worker, as well as our email addresses if you have any further questions. And if you are interested in participating in one of our upcoming webinars, those links are also in the chat box. So please feel free to look at the chat box. And then I'm just going to quickly scan some of the questions. So there were quite a few questions about training overnight. So every child is different and every learner is different. We typically will do daytime training first and have a great deal of success for daytime training before we implement overnight training, unless you're doing the full potty training or full toilet training, in which case you're doing them both. And some of that will really depend on the baseline data and the temperament of the individual and the plan that you're choosing, and the caregiver's ability to support overnight training versus daytime training. So there's just a lot of different variables, but I would often suggest targeting daytime first. And then once you have success, often individuals are trained for 6 months to a year before you start targeting overnight training. Okay, let's see. The slides again will be shared on the drive. We answered some of the questions about ritualistic behavior. Dory, can you see the Q&As?
Yeah, I'm just looking through because there's a lot of them. I think we're going to have to get to a bunch of these after. A lot of them seem to be about specific scenarios and specific kids, and would love to help. In terms of teaching bathroom initiations for children who are dependent on prompts, I think you want to treat that just like any other prompt dependent child. So again, that's why we're avoiding the verbal prompts as much as possible. And we're going to be using gestures. When you're giving your behavior specific praise and your labeled praise, you can praise their independence. And even if at first you're praising independence in a different context, so maybe they're prompt dependent, but they voided without you saying anything. Great job doing that independently. I love how you did that without me having to give you any direction, and that can generalize when you start praising independence, that can generalize across different scenarios. So they might be prompt dependent at first. You can also kind of vary your reinforcer. So if they're prompt dependent, but they took a less intense prompt to void, you can increase the reinforcer, and you can differentially reinforce in that way.
Okay, great. I also want to add that, as the learner is successful with the schedule and they're able to identify the need to go, you could start using natural transition times throughout the day to prompt them to use the bathroom. And then eventually those transition times in of themselves become the prompt. So if every time you walk into the house, once you get home, we transition, we wash our hands, we use the bathroom, that becomes part of the schedule and the routine. And then walking into the house, or before you sit down for a meal or after you sit down for a meal, that becomes the prompt in of itself. All right, so we are just about at the 30-minute mark. So we will keep these questions and we will get the answers out to these questions afterwards. And please feel free to email if you have additional questions or if you're interested in additional training. Again, we only had 60 minutes and there's just so much information to get through. But we hope that this was a helpful introduction, and we encourage you to come to future trainings.
Well, thank you both, Dory and Francine. It was a fantastic presentation. I see a lot of questions regarding the CEUs in the Q&A. If you have not attended a webinar or created an account through Thinkific, you will have to create an account first before it will let you take it. It's free, it's pretty easy. If you are a returning guest, make sure you use that same email that you initially signed up with. Here, you will see a QR code that you can scan with your phone. Also, the links are at the bottom here, was also included in the chat for easier access. So thank you everybody for attending. Like they said, we will be capturing all of these questions that were unanswered and be posting some of them on our socials, which can be found here. All right.